You're listening to the SF Talk podcast, today for the very first time in English. Welcome to the SF Talk podcast. My name is Tomáš Nedoma, and today we have Tzvika Greenbaum from Israel over here. Hi, Tzvika.
Hello. Hi, Thomas. How are you?
I'm fine. How are you?
Yes, getting better, I hope, with the vaccination process that started rapidly in Israel. And we are hoping that also you guys will be catching up with the vaccinations, and then we will be able to meet face to face. Actually, we are going to meet face to face in Košice, but I really hope that it will have more courses will be followed by this course.
Yeah, thank you so much for your words. I also looking forward to meet you in person. For our topic for today, can you maybe start with, can you briefly introduce yourself to our listeners?
Yes, of course. I'm a physiotherapist from Israel. Since 2004, I graduated my bachelor degree in Haifa University. Then I headed to South Australia, to Adelaide, for a combined musculoskeletal and sports physiotherapy master. And you can say that in Australia, I started to get involved quite a lot with cervical spine, upper cervical spine, and headache patients when I was exposed to Mr. Dean Watson, which was a clinical educator in the program in Adelaide. When I returned to Israel in 2008, I started to see more and more cranio-mandibular patients, and that led me to my PhD process together in Tel Aviv University, together with the dental school, in which we assessed patients with temporomandibular disorders. We assessed their cervical spine parameters. So these are my 3 degrees of a bachelor in Israel, master's in Australia, and a PhD in a different university in Israel, in Tel Aviv University. Today, I'm also involved in a postdoc process in a University of Leuven in Belgium. In this project, we are assessing the capabilities of the submandibular muscles, the mouth openers. So we are assessing in a reliable way the strength and the endurance of the submandibular muscles, the mouth openers. So this is my research background. In my teaching background, I teach quite a lot of courses in Israel, but also in the last 5 years out of Israel in many European countries like Belgium, the Netherlands, Greece, Cyprus, and also Czech Republic, and now Slovakia. I also teach in Hong Kong my courses. So I teach quite a lot in a postgraduate level, but I teach also undergraduates in Ben Gurion University in Israel, in Beersheba. I teach the orthopedic rehabilitation course for undergraduates. So this is my teaching background. And at the beginning, I introduced my research background and or my academic background. And now the last thing, but it's not the least, is my clinical background. I see patients several times, or now it's 2 times a week, 2 days a week. I still keep seeing patients in my practice here, where I'm speaking from, in Herzliya Medical Center. I mainly see patients with cervical spine disorders, headaches, temporomandibular disorders, chronic pain conditions, spinal chronic pain conditions. And I gain a lot from my patients into the teaching world and into the research world. So my questions of research are coming from the clinic, and my teaching experience is also coming from the clinic, because I think that's the way it should be. So that was quite a brief but not very short introduction of myself. I hope I did not miss important components.
That's fascinating. It's like you travel the world thanks to your courses and your research. And I'm really happy to have you here. So you specialize for Cerviko-kranio-mandibular rehabilitation complex, and you've already published several researches, and you create your courses. Can you maybe tell us more about the researches which you already published? And you also mentioned me before the podcast that others are coming.
Yes, so my PhD program was built of three main studies. The first one, that was the pilot study that was published in 2017 in the Journal of Musculoskeletal Science and Practice. Formerly, it was the Manual Therapy Journal, the famous one, in which we assessed the upper neck mobility of patients with temporomandibular disorders. So we applied the flexion rotation test, which is a specific test for mobility, rotatory mobility of the upper neck. And we assessed female patients with temporomandibular disorders, and we compared them to the healthy controls. And we found a very clear limitation of movement to both sides in this population. That was the first study ever that assessed the flexion rotation test in the population with temporomandibular disorders. And from there on, we decided to continue, and the PhD itself, that was a pilot one, but the PhD itself included a research on a larger group of patients with temporomandibular disorder, in which we characterized their upper neck performance and pain parameters. And we also assessed the comorbidity of cervicogenic headache in this population. And we found a very clear findings that shows that patients with painful temporomandibular disorder, because there are some others, patients with clicking problems or locking problems, but without pain as the main complaint. But those patients with pain disorders are very highly likely to have impairments in their upper neck. When I speak about impairments, I speak about weakness of their deep cervical flexors and hypomobility in their upper neck. We also found something like 40% of patients with painful TMD having also cervicogenic headache. So the comorbidity of cervicogenic headache was shown to be very high, compared to 5% in the general population. And these were each one of, so one study, one publication was about the mobility and performance of muscular performance of the upper neck in these patients. And the other study that is just about to be published is about the comorbidity of cervicogenic headache in the temporomandibular disorder population. Now, the postdoc that I'm involved now in Belgium, together with the Leuven Catholic University of Leuven, now we are interested in assessing the submandibular muscles. So we are very interested in measuring the performance of the muscles that are opening the mouth. This muscle group somehow was left behind, and they are not well researched. The closers are very well researched in the many studies that were done before, but the openers, from some reasons, were left behind. So this is our focus at the moment, to assess the performance of these muscles, also the protrusors and the depressors of the mandibula, and to see if we can develop a new exercise programs or rehabilitation programs for patients with different disorders in the cranio-cervico-mandibular region. So this is the future direction. We are actually in the process of performing a systematic review of the performance of the mouth openers. And we are in the process of establishing all the studies until today that have looked at the performance of the mouth openers, and the results until now are quite poor. There are not many good studies that assess this muscle group, and there's a lot to be done in the future in that regard.
Sounds interesting. I'm really looking forward to your another papers. Do you have some statistics or some numbers if the temporomandibular disorders or also upper neck disorders are more problems with women or with men?
Yeah, the TMD, the temporomandibular disorder, is very much a sex bias towards females. So we are speaking about 4:1 or 3:1 ratio between females to males. Mm-hmm. And also cervicogenic headache in the same amount of 3:1, 4:1. So it's a very much a gender, female gender biased problem. Very interesting, young females in their fertility age are more prone to develop both temporomandibular disorders, painful disorders of the temporomandibular joint, and also cervicogenic headache.
Okay, so your clinic is full of women?
Is yeah, much more. So it will be, if I see 10 patients a day, maybe 7 or 8 of them are likely to be female. Yeah.
Okay, cool. About courses you create, who are attendees of your courses? Are there all physios or also dentists? Because this topic is also really close to the dentist.
Actually, we established this summer an academy. So my courses, because I have some new instructors that I have trained that are teaching, delivering my courses. So we are the Cerviko-kranio-mandibulár Academy. And in this academy, we teach 5 courses for physiotherapists and 1 new course that is specially for dentists. Mm-hmm. It's not to say that dentists cannot participate in the physio courses, but many times they find some parts of the course not very relevant for them, and they can just observe what the physios are doing. There is some advantage in that. But now we have established a specific course, 2-day course, a craniomandibular therapeutics for dentists. And it's including diagnosis of the masticatory system and the management that is built on dry needling, mainly for dentists, because they are allowed to needle patients without any problems. And it's quite easy for them to learn these techniques.
Yeah. I know that you also specialized for dry needling. So you would recommend dry needling in this area on the head and on the mandibular?
Actually, the academy today have a specific course for dry needling for orofacial pain and headache. It's a 1-day course, but it's only for physios or other clinicians that have already done a basic dry needling course, and also have already done a basic craniomandibular course. So if they have these 2 conditions that met before the course, they can attend the dry needling course, and it's an excellent approach for changing pain in the masticatory system quite rapidly. Of course, in the short term with limitations, but is a very powerful technique to change pain quite immediately.
Okay, thank you. You also mentioned that you have courses for dentists, for physios, like special courses for dentists. In your clinic, do you co-work with some dentists, or I think you mentioned in one of your texts that you also creating the courses with dentists. And what do you think is the importance in physiotherapists to have someone in a way of interdisciplinary approach to co-work like physios and dentists together?
I think it's an excellent combination. The physio-dentist combination is the best combination for orofacial pain patients, because they can be screened well intraorally by the dentist, and they can be managed well musculoskeletally by the physio. And I think it's a winning team for these patients. And I think that the collaboration is also very fruitful between these 2 disciplines. Somehow I find it better than doctors and physios, or orthopedic surgeon and physios. I find that dentists, physios coupling is very successful. Maybe because there is not so much ego there, I'm not sure. Maybe because some other reasons, but I think the collaboration is excellent. I have offered just this year in Tel Aviv University a unique course in the master's program that is all about the interdisciplinary team of dentists and physios for orofacial pain, in the orofacial pain field. And this course was built of my lectures, but also several lectures of professors and doctors from the dental fields. And the feedbacks we are getting from the master students are highly successful. So I think that this collaboration is the future, and is also the present of cranio-mandibular rehabilitation.
Okay, great to hear it. And you have many experiences with physios all around the world. Do you see this collaboration in maybe in Asia or in Belgium? Is it like more common somewhere, or is it everywhere on just on the beginning?
I think that's like many other things. It's slowly developed from specific countries to other countries. I think that in the United States, they have the American Academy of Orofacial Pain, that is the leading body in this field. My PhD was based on a grant from this American AOP, the American Academy of Orofacial Pain, and there is a very successful cooperation for years between physios and dentists. And now I can see it in Israel. For the last 5 years, we are starting to see more collaboration. We see this collaboration also in the Netherlands. I start to see it in Belgium. In the UK, I think there is some collaboration. And more we see it in different countries. In Hong Kong, I'm not sure what was the case. When I gave courses there, it was quite new for them, this agenda of collaboration. But I think in the States and in Western Europe, also in Israel, according to what I know, the collaboration is built more and more, and is also very successful from the patient's point of view. Because the patients really like this option of going to the dentist for one thing, maybe to get the oral appliance, and then coming to the physio for the exercise, for the pain rehabilitation. So I think this it's quite a winning couple. Also, getting referrals from dentists is very easy, because think about it, a dentist, a common dentist maybe see 20 or 30 patients a day, and by opening their mouth for the dental treatment, it's a screening test for temporomandibular disorders. So if he sees like 10% in the population have TMD, so out of 20 patients, you have every day 2 patients that have problems in opening the mouth. And then immediately the dentist can refer these patients to physio. And think about it, in 1 week, he can refer 10 patients to physiotherapy easily. So I think the collaboration, going to knowing dentists and developing a relationship with dentists in clinics in the community is a good way for us as physios to attract new patients into our practice.
Yeah, absolutely agree. It makes sense. Like dentists screen every patient just with opening the mouth. So yeah.
That's the nature of what they do. Definitely, they have to open the mouth, and if they can't, then the problem is quite clear.
Yeah. Can you briefly introduce us temporomandibular joint disorders? Like, how do you divide it, and how we can work with it?
Yeah, so the TMD is a very common disorder. It's prevalent in around 10% in the adult population. As I said before, more female than male. And we have 3 main groups of disorders. One is the pain-related group. The other is the intra-articular group, the discogenic patients. And the third one is the degenerative joint disease patients. It's older patients with osteoarthritis. Each one of them will be managed quite differently, and the management is based quite a lot on the exact diagnosis of these patients. But the pain-related patients will be managed more in a pain management techniques, in the contributing factors for pain management. The intra-articular will be managed many times specifically by the condition of their discogenic problem, if they have a locked problem or if they have just a clicking problem, it's different. And then we have to decide exactly what is the situation mechanically in order to manage the problem. And the degenerative joint patient will be managed very similarly to any other OA patient, like a hip OA patient. So we are improving with our techniques, the range of motion, and then we are maintaining with exercise the condition, and we are trying to stabilize the quality of life of this patient over years of time. So these three families of disorders that is very important to differentiate in order to decide how to manage effectively our patient.
Mm-hmm. So in your courses, you're also teaching how to find out which kind of problem the patient have and then how to treat it.
Absolutely. In my course, I teach to classify patients according to the diagnostic criteria of temporomandibular disorder, the DCTMD. It's the most valid and reliable tool we have today in order to classify patients if they have TMD or not, and which one of TMD, temporomandibular disorder specifically, they have. And this tool is a highly needed tool in our clinic because it allows us to speak within the same language with dentists and also to manage the patients according to the specific problem. We don't have this luxus in the low back still, not in the neck and not in the shoulder, because we don't have a valid and reliable tool to diagnose the specific problem. But in the masticatory system, we do have it, luckily.
Okay, okay. What part during, if you're treating clients, what part of your treatment is manual techniques and what part it's like exercises? And do you have some special exercises for TMD?
So I don't see a big separation between exercise and manual therapy. I see this as one bundle of techniques or treatment that we give. Of course, I use manual techniques for every single patient, but also exercise will be prescribed to every single patient. The manual therapy helps quite a lot to build the relationship with the patient and to change the pain initially, and the dry needling and the manual therapy. And it also builds some commitment, I think, of the patient to the rehabilitation of the home exercises. But without the exercises, we will not be able to maintain the improvement in the long term. And also patients will be dependent in our treatment. And that's not my philosophy. I think patients should get more and more independent down the track. But of course, if they still need the support, we are here for them, but not in a dependent way, but more in the independent way. So they decide when they need to see us. So generally speaking, manual therapy are more in the short-term management to change initially the pain, and the exercise therapy in all the education part is more to reduce contributing factors and to help the patient to maintain the improvement in more the middle and long terms.
Okay, cool. During the screening for your patient, do you work just in a local area, or also do you work with a global approach? For example, if someone has shift the mandibula on a side, do you also check, like, for example, torsion of sacrum?
So this point, Tomasz, is very important that you raised, because then I can use two hats of myself. One hat is the researcher hat, and the other hat will be the clinician or the teacher. Okay, the clinician is the second hat. And the third hat, we have three hats. The third hat can be the educator or the instructor of the course. The instructor hat has to combine the clinician and the researcher, because then I tell you what I need, what I think we need to do.
Supporting by your experience. Yeah.
Sorry?
The researches are supported by your experiences. So.
Yes. But if I go from the research point of view, then what you just said about the rotated sacrum that may contribute to the deviated mandible is not well supported. So we have to say that according to the evidence we know, there's no direct connection, proved direct connection between the position of the sacrum and the function of the mandible. But if specifically I will see in a specific patient that I cannot get good results from more localized techniques, not localized because the neck is always part of it, but if the neck and the jaw are not really responding to what I do, maybe it will be a good justification to assess what's going on lower down in the pelvis, lumbar spine and hips, and then to see if I can get some, gain some benefit in correcting or treating components there. So my logic will be first to go to what is more proved to be relevant. And if I don't get, and if I get good results, that's fine. Then I don't need to go to some other stuff. But if I don't get the necessary results, then I will be more open to the global connections between even the knees and the jaw, or between the lower back and the jaw. But from my experience, we don't need to go there very often. Sometimes, yes, but it's not that every second patient that get into my clinic, I assess his hips in order to help his jaw. But maybe every 20 patients, then I have a heart case, and then I have to think, okay, they're not responding. Let's see what's going on in different parts. Or sometimes it will be only a distraction to take their focus from the pain to somewhere else. Sometimes it will work by this way, not by a biomechanical connection, but sometimes just distracting the patients from their problem and concentrating in other parts in their body sometimes gives them a better perspective to improve their job.
Okay, thank you. So you work like step by step, and the area you're treating is increasing. Yes. As you mentioned, if it doesn't work over here, you work in different place. Cool.
Yeah. But the neck and the jaw for me are always, almost always dependent in each other. Okay. So I will assess the neck of every single patient with painful TMD. The neck, and when I assess the neck, I look at the shoulder blades as well. Yeah. So I'm already halfway through. Yeah. So I'm not very far from the lumbar spine, but so it's to say that I'm already working holistically, but maybe not all the way to the lower limb very easily. That would be more accurate.
Yeah. Thank you for your answer. As you mentioned, one of your teachers in Australia was Dr. Dean Watson, expert on headache. How did he affect you in terms of pain, and how do you perceive the pain right now? And what do you think, like we as therapists, as to work? How do we work with the pain? What's the importance of, for example, biopsychosocial spiritual approach?
So you mentioned Dean, and Dean is an excellent clinician and excellent also a teacher, and also a researcher, quite fresh researcher. So he's basically a clinician before everything else, and that's good. And Dean is treating the neck very much in a Maitland way. So he's not very much into the biopsychosocial approach, but he's a lot in fixing the gliding of the facet joints in the upper neck, or balancing the muscles. So Dean is a more 70s, 80s, 90s type of therapist. Excellent therapist. Yeah. So he actually built his all of his clinic on the upper 3 segments of the neck, and his techniques are excellent. And I teach some of his techniques, modified by my experience, and by also got his permission to do that, because we worked quite a lot together when I was in Australia. But speaking about the biopsychosocial approach, then of course, when we are managing patients with chronic headaches, chronic orofacial pain, temporomandibular disorders, if we will not understand this axis, the psychosocial axis of their problem, we are very likely to fail with their management, because the science, the research shows us that 70–80% of patients with chronic TMD have also either anxiety disorder or depressive disorder. So you cannot overlook on that fact. So it means that out of 3 patients, at least 2 will have either depression or anxiety. And if you don't address that, it's very likely that their disorder will continue until we'll find a way to help them to calm down or to cheer up. It depends. If they have more anxiety, it's more the anxious patient, then there are specific approach that we can address as manual therapists. Mm-hmm. And if you have a depressive patient, then you have some different approaches in order to encourage the patient to take steps in order to help himself. These are things that I also speak in my courses: how to approach the depressive patient, how to approach the anxious patient, how to approach the somatic patient. So psychosomatic patient, the patient that tells you that I'm fine, I'm not anxious, I'm not sad, but his body is speaking. So you can see that it has a somatization. And then there are different approaches with these patients. So it's getting really interesting, as you can see. Every patient is different, and we have a lot of work in order to decide which problem has each patient in the psychosocial component in order to help him.
Mm-hmm. Great. You're currently working on another research regarding headache. Can you tell us more about how to divide the headache and how to manage it?
Yeah, so I'm at the moment in the process of writing a masterclass for musculoskeletal clinicians about headache. So it will be headache in the musculoskeletal practice. And I think that there is I've developed a nice approach in categorizing headaches according to the prognosis as physiotherapist. What do I mean? So if you have patient with a cervicogenic headache, for example, which is a very much or purely musculoskeletal disorder, then his prognosis with physiotherapy is excellent. So this patient in the light, so there is a light theory or the light approach for headaches. So we have the green light. So this is a green light patient because his problem is very likely to improve with physiotherapy. Then if we have patient with migraine, chronic migraine, but also some cervical spine and jaw components, all right, musculoskeletal components. So the migraine is a neurological condition, that's right. But we have some musculoskeletal factors that are contributing to the migraine. Then this patient becomes a yellow light because we are not sure whether we are likely to help him or not. But if this same migraine patient will have musculoskeletal disorders or components, then he will become an orange light, because then this patient is not very likely to get benefit of physio, because what can we help this patient apart from listening to him? Because if he has no cervical spine disorders, no masticatory system disorder, then we cannot help him. And then we have the red light. So that can be a patient with oncological problem that is being expressed by headache, for example. And this patient we have to recognize as a red flag patient. And of course, this patient has to be sent to the doctors to be managed quite quickly. But we have to screen this patient as a red. So we have the green light for musculoskeletal headaches. Then we have the yellow light for neurological headaches that have some musculoskeletal component. And then we have the orange light for patients with neurological headaches without any musculoskeletal component. And the last one is maybe the first one will be the red light, that patients that have a serious medical condition that has to be solved very quickly.
Cool. So when we can read more about this research, this approach?
I really hope that within a few months this will be published as an article, but participants that will join my courses, of course, will not need to wait for that, because they will hear about it before in the course, during the course.
Yeah. So your next travel to Czech or Slovak is in the end of the January. So you're heading to rehab care in Košice. Is it right?
Yes. So I have a long journey from. I hope that it will happen with the COVID-19 issues. Yeah. But I will approach on the 29th from Tel Aviv to Vienna. And then from Vienna, I will be picked up by Eva, and she will go with me all the way to Košice, a few hours. Then on the 30th, the 31st, I will give the first Temporomandibulární rehabilitation course in Košice. And then I will approach back to Vienna and back to Israel on the 1st of February. So that's the plan. And I'm really looking forward to see the Slovakian physiotherapists joining the course, my first course in Slovakia. I'm really looking forward to that.
Nice.
I'm excited for that.
Great to hear it. Yeah. I hope that I also can attend your course or meet you in person, because it will be a pleasure to meet you.
Thank you. Same for me.
Yeah. So thank you so much for really interesting information you shared with us today. Is there something else you would like to add?
I think that this topic is one of the most important future topics for physiotherapists, because we as physio always need to think, what is the next field we can get into? How can we contribute more in order to expand our world? And I think the cranio-mandibular region is one of the regions that we can develop and gain new work for us, and more important for that, gain new benefit for our patients.
Yeah, I absolutely agree. I don't think that this area or this kind of manual therapy is what the physios really often are taught in a school. So yeah, absolutely.
It's about time for our physios to get into this field and to take the ownership on this field, because it is a musculoskeletal condition that should be managed by a musculoskeletal expert. And who is the best musculoskeletal expert? I believe it's us as physiotherapists. So we just need to offer our service to these patients, because they're looking for clinicians like us to help them.
Yeah, absolutely agree. Okay, Tzvika, thank you so much. I hope we will meet soon. And one more time, I wish you a safe flight, and in 2 weeks in Košice.
Thank you very much, Tomáš, and thank you for all the participants and the listeners for this podcast. Looking forward to see you soon in Slovakia and in the Czech Republic. Goodbye.